we'll turn to an area that's really an enormously controversial area. It's one that actually chewed up a better part of a year of my work in a consensus conference that we put together because we wanted to ask, what is the role of gene expression profiling prognostically, predictively? And so what a really brilliant resident we've had the pleasure to have working in our melanoma program for the last year, and who's actually already published several things on his work and is going to present more at ASCO this year, Andrew Knight, will talk about non-invasive detection and gene expression profiling in melanoma. Welcome, Andrew. Thank you for talking today.
Thank you for that introduction, Dr. Kirkwood, and thank you all for being here today. I will not be having you exercise, but hopefully I can still keep your attention with some of the information I'll be presenting. So as Dr. Kirkwood mentioned, I'll be talking about non-invasive detection or detection of melanomas using techniques other than traditional biopsies, and also gene expression profiling, looking at the DNA of these tumors to try to understand how they will behave over time. So to give an overview of what we'll be discussing, we'll be talking about why it's so important to diagnose melanomas as early as possible, how we usually go about doing that, how we do that traditionally, and then how we can use some of the tools I'll be talking about today to potentially augment this approach. We then will also talk about looking at the DNA of these tumors a little bit more in detail. Can this tell us what the risk of recurrence is for these patients if these tumors behave more aggressively? So to jump into it, this is information that's pulled from the National Cancer Institute, looking at the incidence or the prevalence of melanoma over time. And as you can see, melanoma is on the rise. This is just a 20-year period, and we see a significant increase in the number of melanomas that are diagnosed, representing that this is a growing issue and all the more reason that we need ways to accurately diagnose these patients early. To highlight the importance of early detection, it's important to understand the difference in outcomes that we see for these patients depending on the stage at which they're diagnosed. So looking at this graph, you'll see this blue line at the very top there. That indicates patients with localized disease that's potentially curable with surgical resection. Down at the bottom, you'll see this pink line indicating patients with metastatic disease or disease that is spread distant from the original site. And you can notice the gap between the two, that the blue line higher up on that graph indicates better outcomes, better survival than the patients who present with more advanced disease. Now, one exciting point I will highlight on this graph is that there's a rise in that survival in the pink line in the patients with more advanced disease, which signifies the benefits of these therapies you've been hearing about today. So while there's significant benefits that have been made for these patients, there's still a discrepancy between the patients that present with more advanced disease and those that we're able to catch as early as possible. So how do we go about diagnosing these? There's really the main tool that's used is visual inspection. Because these tumors arise on the skin, we have the benefit to look at lesions as they come up and to see if they look concerning. This is looking for the ABCDs that you may have heard of before. And we can simply look with our eyes or look using a tool called a dermatoscope. And there's an example of this highlighted in the bottom left of what one of these looks like, but it really magnifies the lesion and illuminates it so that you can better characterize if this is truly something that looks concerning or not. And using a technique like this can improve diagnostic accuracy, but it does come at the cost of being a specialized tool, something that requires some training and expertise to use. So while your dermatology providers may be very familiar and very comfortable with this, general practitioners, for example, may not. So ideally, in a perfect world, we'd be able to lump patients into really one of two buckets. Either these are lesions that appear benign, in which case we can just watch them, keep an eye on them, which we refer to as surveillance, or they're much more concerning, in which case they warrant a biopsy. But this really underestimates the spectrum of disease that we see for our patients. We have lesions which have some features of a benign lesion, but have some features that are a little bit more concerning as well. And so we have these intermediate risk lesions along the middle. And it's really these lesions that present a challenge of what do we do with them? If you biopsy most of these lesions, then certainly you can catch more melanomas potentially, but at the risk of increased biopsies and any complications that come from that. Of course, if you err on the other side and of not biopsying, you risk missing a melanoma, which certainly none of us want to do. So in practice, what happens with this is that there is considerable variability between different providers, different specialties about exactly which lesions are biopsied and which are not. Ideally, we would have a technique to take these intermediate risk lesions and to stratify them or to separate them into one of the two buckets that I had identified here. So in order to talk about how to find these early changes that signify that something is a melanoma or is becoming a melanoma, we need to talk about how those develop. But talking about the limitations of the current approach that we use, as we biopsy lesions, we create risks, even if they're small, of scarring, bleeding, and infection. And so minimizing that while trying to maximize biopsying the lesions that are truly melanomas is key. Additionally, something that is not as commonly talked about is the importance of the right type of biopsy. The American Academy of Dermatology recommends that for a lesion where there's very high concern that it is in fact a melanoma, that it be excised, taking a scalpel to remove the lesion, rather than simply having the lesion be biopsied by a shave technique where just the top layer is removed, because that can risk missing some of the most important information about the depth of that tumor, which is so key in guiding future treatments. And so if we knew better how high risk these lesions really are, it could potentially guide the type of biopsy that we do. And the other thing I'll highlight is that even with trying to be cautious and biopsy lesions as they appear concerning, there are melanomas that are missed. We'd like to think that we don't miss any, but we know by looking back that we do. And depending on the study you look at, the sensitivity of a dermatologist is somewhere in the range of around 75 to 80%. And for routine examinations by a general practitioner, it can be considerably lower because of all of the other medical issues they're trying to address. One study quoting as low as in the 40% range. So it's important that we have techniques to try to increase that sensitivity. So I said we would talk a bit about the changes that occur in melanoma over time so that we can try to detect these at the earliest stage possible. And so one of the first changes that happens in any tumor, but in melanoma as well, is a change in the DNA. So we're familiar that sun exposure is, of course, a risk factor for developing melanoma, and this is because of the damage to the DNA. If you're not familiar with that, you can think of it as the DNA as the blueprint for a tissue, how it behaves, sort of the guidebook of how it will behave and act over time. And changes in this can cause these tissues to act as cancerous lesions rather than simply benign ones. So as this damage occurs to the DNA and these mutations develop, we can eventually see as these lesions grow and change on our examination, but that is a later development. And so if there's a way to look at these genetic changes early on, it potentially opens an avenue to diagnose these patients at an earlier stage. I'm going to highlight 3 genetic mutations that have been identified to be particularly useful for this purpose. You can see the full names here, which I won't read out, but essentially I'll be referring to these as LINC, PRAME, and a mutation in a portion of a gene called the TERT promoter. And these genes were identified to be, the LINC and PRAME genes were identified to be more highly expressed in melanomas than in benign lesions. So this led a group of researchers to develop something called the Pigmented Lesion Assay. And UPMC's own Dr. Laura Ferris has done a lot of work in this area to try to bring this to the clinic. Unlike a traditional biopsy where tissue is removed, this is a simple adhesive patch that is firmly applied to the lesion and then removed, where a thin layer of cells will be taken away and can be sent to look for genetic changes to determine if this is something that we should send for biopsy or something we can potentially wait on. So how good are these tests? I'll highlight the first generation of this test, the PLA, which looked at just 2 of the 3 genes I mentioned. And it showed that if changes occur in one of these 2 genes, that if these genes are more highly expressed, that will pick up 91% of melanomas. So if the lesion is in fact a melanoma, in other words, that is a 91% chance that test will come back positive. They didn't stop there though and look to see, can we make this better? Because 91% is good, but if we could get it to be even higher, we could feel more secure about trying to guide our management in this way. So this is where the integration of that 3rd gene that I talked about, the TERT promoter, came in to develop what they call the PLA plus, or the Pigmented Lesion Assay plus. This improves the sensitivity. It's going from 91% of lesions that are in fact melanomas being picked up by this all the way to 97%. And one thing I'll point out here is that a particular diagnostic challenge can be these dysplastic nevi, these abnormal looking moles that are certainly can be concerning visually and can sometimes even appear as early stage melanomas on a biopsy. And while the first 2 genes I mentioned, LINC and PRAME, can be overexpressed in these dysplastic nevi, it's rarely the case that they, unlike melanomas, will have mutations in this TERT promoter, again, giving us a way to separate out those 2 groups. So let's go back to this model that I highlighted earlier about our clearly benign lesions versus our intermediate risk ones, and finally our very clearly malignant lesions that should be biopsied regardless. The proposed way to use this would not be so much for the lesions that are clearly benign, where we can feel safe just watching them, or clearly malignant, where we know we shouldn't delay and we should go ahead and biopsy, but for these lesions where we're on the fence, essentially. Can we then do a test like this to determine where to send them next? I do want to be clear that this would not be a substitute for a biopsy, that if this came back as concerning for high risk, that information we were just talking about from the tissue is so important to guide treatment that the next step would be to do a biopsy, confirm the diagnosis, and get more information about the tumor. So the benefits of this, exactly what I was talking about as potential unmet needs for the field, is to try to detect these tumors earlier. It's not something that requires specialized training. This is an adhesive patch that can be applied to a lesion, removed, and sent off to a specialized lab to do the training. So unlike biopsy techniques that some general practitioners, for example, may not be as comfortable with, this does not require that. And it's non-invasive. Because it's not removing a significant amount of the tissue, it doesn't open you up to those risks of scarring and infection, that sort of thing. And the goal would be that you could test this, and if negative, potentially say to hold off on doing the biopsy right away if you weren't totally convinced, and therefore potentially reduce unnecessary biopsies. So I want to shift gears a bit and talk about another area where genetics can potentially tell us about these tumors. So we saw how it can differentiate, or has the potential to differentiate, benign lesions from malignant ones. But what if we know the patient has melanoma? Can the genetic changes of that melanoma tell us about how it's going to behave, what their risk of recurrence is, or that it is spread somewhere like the lymph nodes where we know melanoma likes to go? So I'll highlight first the way that melanoma is typically excised, so we can talk about the principle of recurrence, and then talk about how these tests could in the future potentially be useful to guide this. So if in this example, we have a melanoma of this patient's right arm, it's fully excised with the goal of removing all of the cancer that's there. But we know that there's the potential that we're leaving something behind. These are a few cells so small that you couldn't detect them on an exam, that you can't detect them with any sort of scan. But we know that some of these patients, if the tumors are particularly thick or there's other high-risk features, that there could be something left behind. This is the rationale behind what Melissa Wilson talked about earlier of adjuvant treatment to try to get rid of anything that's left. So it's important, though, that we understand who is truly at high risk and would really benefit from therapy to try to remove any cancer that's left, versus patients that are at lower risk, where the toxicity of a therapy could outweigh a potential benefit if they are really unlikely to recur. So how can looking at the genetics or doing what we call gene expression profiling try to start to answer that question? And I'll highlight one commercially available assay as an example of this, but just understand that these all function similarly. So this example, the Decision DX melanoma test, looks at 31 genes in a patient with melanoma that are associated with higher or lower risk of recurrence, and creates a score that places the patient into one of 4 categories, from lowest risk up to highest risk. And so if we look at how these patients do over time, depending on the bucket that they fall in, we see something that looks like this. So just to orient you to the graph we're looking at here, as we go over towards the right, that is the patients being followed by over time, and looking at the y-axis, or how high these lines are, that is indicating whether or not the patients have recurred. So anytime a patient recurs, that's that line dropping down, or if a patient dies, of course, that would also count. Now you see that there's a separation. The patients with the lower risk profile have better outcomes than the patients with the higher risk profile. And so this highlights that this does have some potential value to suggest the risk of a patient. Dr. Kirkwood did an excellent job of highlighting that this is a controversial area, though, because knowing that a patient is a little higher risk or a little lower risk is not sufficient to answer all of the questions that we have about this. It's important that we understand how these risk categorizations should affect what we do in the clinic. Should we space out surveillance on patients that are lower risk, or perhaps do it closer if the patient's at higher risk? And the reality is that those trials really have not been done yet. So we don't fully know the answer to exactly what that would do in terms of a benefit for the patients. If using this to guide our approach would really benefit the patients, that's something that is certainly being looked at and is an attractive option for the future. Dr. Kirkwood mentioned the Melanoma Prevention Working Group, and I pulled a segment from their statement on this exact topic, highlighting that they are optimistic about the potential use for this, that this could be a tool in the future to narrow in on exactly a patient's individualized risk. But we need those prospective studies. We need those randomized controlled trials to understand if patients should have their treatment or their surveillance modified by a gene expression profile. So in summary, we talked today a bit about non-invasive detection. These are techniques other than biopsy that can put a patient in one of those 2 categories so we know what to do with them going forward, to try to pick up on every melanoma while not biopsying things that are not melanoma and don't need to be biopsied. And hopefully with this, diagnose patients at an earlier stage and move some of those patients from that pink line I showed you at the beginning up to that blue line at the very top and improve those outcomes. We also talked about the gene expression profiling as a tool to better estimate a patient's risk of recurrence, but highlighting that exactly how we would use this information in the oncology clinic is something that still needs to be better determined before we see widespread use of this to change our management. And with that, I just want to acknowledge, of course, Dr. Kirkwood for inviting me to speak today, everyone at the Melanoma Center for all the work that you do, and the Cancer Center more broadly for the work that all of you do, and of course, our sponsors today who help support this event.